Hello everyone. So I've got another TOG article here. This is the management of women who decline blood and blood products in pregnancy. Quite an important TOG, not just for your exam, but also for your clinical life, as this is something that you will come across in your careers at some point. Please don't forget to give this video a thumbs up and subscribe to my channel if you haven't already. So, what are the risks of blood transfusion? So, just by having incorrectly prescribed blood components, there can be transfusion reactions, there can be transfusion related acute lung injury, there can be immune complications, there can be transfusion transmitted infections. There's a serious hazards of transfusion, shortened to SHOT, which is a voluntary confidential scheme that compiles and reports of adverse events resulting from transfusion of blood and blood components in the UK. So it's the Jehovah's Witnesses, which is who are member of Christian group, who are generally your patients who would decline blood products. So there are about 130,000 people of the Jehovah's Witness in the UK. They do not accept whole blood or primary blood components like your red cells, platelets, or plasma. Decision about clotting factors and autologous transfusion or immunoglobulin products like anti-D is an individual one. So autologous pre-deposit is never acceptable to Jehovah's Witness, but where transfusion circuit is maintained in continuity, like sometimes in cell salvage, then this may be acceptable to them. So in 2006, the cost of giving blood, which is 1 unit of RBC, was 140 in the UK. That's mainly because of leukodepletion to reduce risk of infection. In obstetrics, about 3% of all blood red cells are transfused, so quite a large number. Mortality rate of hemorrhage is about 0.66 per 100,000 maternities in the UK. So legal issues. So in the UK, the law is very clear that if the woman is competent and she's refusing any treatment, no matter how important that treatment is, then she has the right to do so. Nobody can do that for her, provided she's competent. There is a role of advance directives, and in the UK, it can be quite traumatic for the healthcare professionals who are involved in looking after a patient who may lose their life just on the basis of that they declined blood products. In the case of Jehovah's Witness, what is acceptable to one person may not be acceptable to the other, so it's important to make an individualized plan. But it is important to work with the patient and reach an agreement about this antenatally so that there is no confusions and the patient also had lots of time to think about what they'd like to do in case of an emergency. So antenatal management, so preconception care, so it's important to optimize HB levels and to identify any risk factors for postpartum hemorrhage. So booking, if the patient declines or, it's important to check if the patient would decline or accept blood transfusion. If they would decline, then this would prompt a discussion for the reasons and the implications, and if they are considered as high risk, then they should be triaged to a consultant care. Routine booking blood should be done, including full blood count and group and save. It's important that women understand why a group and save sample is taken, and an open discussion about need of anti-D in rhesus negative women, and the fact that this is obtained from human blood products. So advanced directives are legally binding document. Reason for refusal of blood, basic understanding of function of different blood components, and they may have some precise and specific wishes. They should all be documented. They may not have considered where to draw the line and whether, for example, immunoglobulins or clotting factors would be acceptable. So consider confidentiality and appreciate stated preferences influenced by the person accompanying and make sure they're not influenced by the person accompanying her. So, optimizing iron stores, antenatal anemia, secondary iron deficiency anemia is treatable with oral iron. Parenteral iron is helpful in resistance cases or late bookers. Um, Identifying risk factors for hemorrhage, so things like placental site should be identified. MRI can help in aid the diagnosis. Also, if there's any presence of any fibroids, this can increase the risk of postpartum hemorrhage. Also, there's any clotting disorders, again, these increase the risk of bleeding, and they should all be corrected. Planning for deliveries, women who decline blood products preferably should have a deliver at a regional center with intensive care, cell salvage facilities, recombinant factors, interventional radiology, and staff who are familiar with management of such patients. So blood conservation techniques include, so this all should be discussed in advance. So things like intraoperative cell salvage, acute normal volemic hemodilution, perioperative autologous donation. So, in the seventh report of the confidential inquiries into maternal death in the United Kingdom, it was reported that consultant anaesthetist involvement is necessary during the antenatal period, informed consent for RBC salvage during surgery and infusion of salvaged blood, and clearly recorded in the case notes. All women who are known to have stated a wish not to receive blood products should be seen by a consultant obstetrician and anaesthetist at the onset of their labor and a final care plan developed. Intraoperatively, they should have an advance directive. If the woman has not previously attended for care, then she should have then everything should be covered thoroughly and quickly with attention paid for documentation. Senior obstetric anaesthetist, midwifery and hematology staff should be informed and made aware, and once the patient's arrived on labor ward, then intravenous access with full blood count should be obtained. If the woman has consented for cell salvage, then the machine should be sought out and brought and looked into, and kept ready. In Why Mothers Die 2002, the sixth report on confidential inquiries into maternal deaths in the United Kingdom, consultant obstetrician either performs or directly supervises the caesarean section if this procedure is indicated. So postpartum management is active management third stage, which helps reduce BPH by 60%. They should not be left unattended for the first hour after delivery. Perineal damage should be repaired promptly, so as to minimize blood loss. If there's additional risk of bleeding to placenta previa or a complicated cesarean section, then interventional radiology should be available and contacted, and early intervention should be sought to help reduce mortality and morbidity. Aggressive treatment of BPH, anticipation and managing aggressively, standard pharmacological treatment plus insertion of any intrauterine compression balloons may be required to help with managing bleeding. Uterine or iliac artery embolization or ligation may be attempted before proceeding to cesarean hysterectomy. There should be low threshold for medical and surgical management, including hysterectomy. So, treating postpartum anemia, the British Committee for Standards in Hematology does not recommend transfusion unless the hemoglobin is 7 grams per deciliter. Anemia can be treated with iron. Postpartum iron deficiency, there's a faster rise in the first 6 weeks with BD oral iron given compared with 2 doses of IV ferrous sucrose. After that, there is no significant differences into how quickly the iron stores recover. This is again taken from the TOG article, an example of the advanced directive for women who decline blood products. Every patient who does decline blood products should have one of these filled out in their notes, documented in a secure manner, so that everybody is clear as to how to manage these patients and also what this particular patient's wishes are. Well, that's it. Many thanks for watching, and I hope you found this video useful, and if you did, then please give this video a thumbs up and subscribe to my channel if you haven't already, and let me know if there's any other content that you'd like to watch.